Hello, I'm Dr. Larry Goldenberg. I'm a professor of urologic sciences at the University of British Columbia and a urologist at the Vancouver General Hospital. I'm also a co-director of the Vancouver Prostate Center. The purpose of this video is to introduce you to the prostate gland as a newly diagnosed patient with prostate cancer. At the end of this video, I hope you will have an understanding of what the prostate gland is, what prostate cancer is, and what the best possible management might be for your disease. Now, you're not alone. In Canada, 25,000 men will be diagnosed with prostate cancer this year. It's estimated that 1 in 6 to 1 in 7 men will actually be diagnosed with prostate cancer sometime after the age of 50. Many of these men are going to have difficulties in making their decisions, just like you might be having. So I hope that this video will help you understand and help you make an informed decision. Over the next few minutes, I will explain the anatomy of the prostate, what its function is, and how cancer arises from the prostate. After that, we'll talk about the different treatment options to help you make an informed decision. The prostate is a gland that sits below the urinary bladder in men. This is a very important gland because its secretions maintain the health of sperm as they travel through the reproductive process. Now, the prostate in aging males is prone to develop several different problems. In many men, the prostate will grow naturally and begin to block up the urinary channel and cause urinary symptoms. In other men, prostate cancers can develop in the prostate. And in some men, you can get an infection or an inflammation of the prostate. All of these diseases are separate entities, but they may present with similar symptoms. So, for example, you may have trouble with urination that could be due to benign growth or to an inflammation. A very important message is that prostate cancer, particularly in its earliest stages, does not cause symptoms. So you need to be checked, and you make sure that all of your family members and friends get checked as well, because prostate cancer, when it's diagnosed at an early stage, is very curable. So now, where does prostate cancer arise from? Well, as I mentioned, the prostate is a gland. It makes secretions. Now, these secretions come from cells which line the glands and ducts of the prostate. Each one of those cells has the potential to become cancerous. Once that cell becomes cancerous, it loses its normal control mechanisms that normal cells in the body have, and it starts to grow faster. And when it grows faster, it becomes more aggressive and can actually find its way outside of the ducts or outside of the glands into the support structures of the prostate, where it then continues to grow, and it turns into small lumps, which then become larger lumps. And then these larger lumps can become dangerous as they pass on to other parts of the body. And that's when men run into real life-threatening situations. But if you can catch that cancer when it's just a small clump of cells, then you can cure it. And there, as I mentioned, we'll discuss some of the different treatment options. The prostate is a gland that sits just underneath the urinary bladder in men. Urine passes through the middle of the prostate in the urinary tube, which we call the urethra. The prostate itself is a gland that makes secretions which come out in the ejaculate and are very important for healthy reproductive life. Now, just below the prostate, there is a control valve or a muscle called the sphincter. This is a voluntary sphincter that you could use to stop and start your urinary stream. The prostate itself and parts of the bladder are important for urinary control as well. The prostate is also a very important organ for sexual function in that there are nerves and blood vessels which pass by the prostate to the penis, which are very critical to normal erectile function. As a gland, the prostate also makes a protein called prostate-specific antigen, or PSA. PSA is very rich in the ejaculatory fluid, but some of it normally leaks back into the bloodstream. In cancers, more PSA is made and more of it leaks into the bloodstream, so we can pick up an elevated level. And that's probably one of the reasons why you had your biopsy and how your cancer was diagnosed. Now these glands are where the cancer arises. Each gland has small cells that are lining the interior of it. Those cells can become malignant. A cancerous change happens within the cells, and then that cell loses its normal control mechanism, so it starts to divide faster and faster, and you get a buildup of these cells. At the same time, they can break through the walls of these ducts and glands and spread into the supporting tissues of the prostate, where they really take off and start to build up into lumps. Once there is a lump that can be felt, you're at a little bit more of an advanced stage. Now, going back to these cells, we can categorize how aggressive a cancer is growing by the appearance of these cells under the microscope when we do a biopsy of your prostate. So you've had your biopsy, and the pathologist has looked at your cells under the microscope and has applied a grading system to those cells which reflect the aggressiveness of the cancer. A very clever man named Don Gleason looked at many prostate cancers, and he realized that the appearance of the cells and the architecture of the cancer actually correlates to the aggressiveness of the cancer. So he looked at the very mildest forms of cancer, and he assigned a grade to those of 1. And then the more aggressive cancers were 2, and then 3, up to a grade of 5. So he was able to stratify cancers from least aggressive to most aggressive by a scoring system of 1 to 5. When we do a biopsy, we pick up different cancers within their prostate. Not all cancers are the same within your gland. Some of your cancer might be grade 2, some of it grade 3, some of it grade 5. Depending on what the needle found when it took these cores out of your prostate, the pathologist will grade and quantify the cancer. What he will tell you is that you had a lot of one category, perhaps 3, but you had a little bit of another category, perhaps 4. And when we add those two numbers together, it gives us the Gleason score. So in that scenario, it was 3 plus 4 equals 7. So you would have a Gleason score of 7. If it was 4 plus 4 or 4 plus 5, clearly it would be an 8 or a 9. Now the Gleason scoring system has become our best way of predicting how a particular cancer in a particular individual will behave. It is not perfect, and what we see as a score on your biopsy may not reflect ultimately what is actually going on in your prostate, because as you know, the prostate biopsy was just a sampling. It was like sticking a pitchfork into a haystack. Now in that haystack, there may be a beach ball, and we could have caught just the edge of that beach ball. It could have been a golf ball, and we caught the golf ball. Maybe there were a softball and a beach ball, and we caught a little bit of both of those. But we don't know for sure, just from the sampling, what exactly is going on within that haystack, the analogy to your prostate. We make an educated guess, and we wish we had a crystal ball, and certainly we're seeking that holy grail of being able to predict, just from a biopsy or a blood test, how your cancer in your case is going to behave, and then how we would recommend that cancer be treated. So prostate cancer comes in all shapes and sizes. Even within your own prostate, you can have different grades of cancer. Now there's a couple other terms that you're going to hear that are important. One of those terms is stage. Your doctor is going to tell you that you have a certain stage of prostate cancer. And what he's talking about is the amount of cancer that is in your prostate. If their lump has become large enough that we can actually feel a bump, we call that a stage 2 or a T2. If your PSA is elevated, but your prostate feels soft and benign, we don't feel any lumps, but we do the biopsies and we find cancer, then you're what's called as T1C. The more advanced the cancer is, the higher the stage. So if you're a stage 3 or a T3, it usually means that the cancer is already beginning to spread outside of the prostate into its surrounding tissues. and a T4 is the most advanced stage. When we talk about treatment, we have to personalize the treatment or tailor it to your cancer, to its features, to your medical condition, to your social condition, and ultimately to your own preferences. As physicians, we can give you an idea, sort of an educated guess, as to how much cancer you have and how likely that cancer is to spread and become life-threatening. Grade is the other very important feature, which I've already discussed. And thirdly, the actual value of the PSA and how the PSA has changed over time will also help us categorize you into what we would call a high risk, intermediate risk, or a low risk type of a cancer. And that helps guide you and us into the appropriate treatment realm. So what do I mean by those risk factors? I think a good analogy is the barnyard analogy. Pretend you walked into a barnyard and there's a bird, a rabbit, and a turtle. Now, when you walk in, you're going to startle the bird and it's going to fly away. Now, if you've got a good bow and arrow or a gun or a net, you probably catch some of those birds, but many of them are going to be gone before you can do much about it. The turtle is going to sit there, maybe poke its head out of its shell, have a look at you. It might start to move around, and eventually it could find its way out, or if it's really close to the fence, it could get out a little sooner. The bunny rabbit is going to start to bounce around, and eventually, sooner than later, we'll get out of the barnyard. So if we use that analogy and you think about prostate cancer like those three animals, a low-risk prostate cancer is like a turtle. It will grow. It is a cancer. It's going to move, but it's going to move very slowly. And in fact, in many men, that cancer may not have any impact whatsoever on lifespan or general health. The other extreme are the birds, and they account for the 4,000 deaths we see every year in Canada for prostate cancer. So clearly we want to find the birds, and we want to be very aggressive in managing those birds because we want to do the best we can for those men and prevent death. And then a large number of these cancers are like the bunny rabbits. They just hop around there, but they're going to grow steadily. But we have a good chance of capturing them and getting them under control. So depending on your risk strata, your category, low, intermediate, or high, the treatment will differ. Once your doctor has told you what risk your cancer is, that is low, intermediate, or high, we have to look at so many other factors, and you have to consider these in making your treatment decision. These factors include your general medical health, your age and life expectancy, perhaps family history, your social history, your sexual health, your urinary health. So there's many factors that come into play, and you want to discuss these all with your physician so that you're very clear on what is best for you. I often think about making the treatment decision like buying a stock. You're not going to just go out and buy any stock. You're going to do your due diligence so that at the end of the day you're comfortable in putting your money down. So irregardless of the outcome, you will feel comfortable that you made an intelligent decision, you made an educated decision, and therefore you'll have very little regret no matter what the outcome is. Same with making a decision for a medical therapy. Now we have many options for prostate cancer, and that's sort of good and bad. Sometimes it would be nice if the doctor could say to you, you have one choice, take it or leave it. But with prostate cancer, we actually have the luxury to have multiple choices. And again, we have to tailor that to your needs and what we feel and what you feel is best for you. So the different treatment options are listed here. We have active surveillance, surgical treatments, radiation-based treatments, and hormonal-based treatments. Your doctor has told you that you have low-risk prostate cancer. Your treatment options include surgery or radiation, either today or on a deferred basis, or perhaps never. So we could have a treatment today that we call active surveillance with possible delayed intervention. So let me start with that. Because your cancer is small, low grade, your PSA is not very high, there's a chance that you have the type of prostate cancer that will just linger in your body, maybe grow very, very slowly, and sometime in the future could show signs of progression from a turtle to a rabbit. And we'll be there at that time to look after you. So this option of doing nothing may be very appropriate, and it's one that you should discuss with your physician. Active surveillance is just that, though. It is an active process. You need to have your blood tested on a regular basis. You need to have regular rectal examinations of the prostate. And you need to have intermittent biopsies of the prostate. In addition, your doctor might want to evaluate your prostate with an MRI or a CT scan. It's very unlikely that your cancer has spread to other parts of the body, so you don't really need to have a bone scan or other tests looking for cancer elsewhere. They're very, very unlikely to be helpful in your case. Now, if you feel that you want to proceed to a treatment, or that over time your cancer has shown progression, so that maybe it's turning into a bunny rabbit, then you need to think about the two gold standards. These are surgical or radiation. So I like to describe them as a nice looking fruit bowl with an orange and an apple. Now, you may like oranges, you might like apples, but you've got to decide which one is best for you. And you can't go wrong with either one. We don't have the science backing yet to be able to say that radiation or surgery is better than the other with respect to cancer control. They're both very, very good. Now, there may be some reasons why you prefer surgery or radiation, but it's very important at the end of the day for you to be comfortable with your decision. Let's talk about surgery. The surgery that we do for prostate cancer is called a radical prostatectomy. This involves the surgical removal of the prostate and two little pouches that are attached to the back of it, sort of like storage containers for ejaculatory fluid, that are called seminal vesicles. When the prostate is removed, the urinary bladder is re-sewn down to the urethra so that you can urinate through the normal urinary channel. The valve, which we refer to as the sphincter, is maintained so that you have urinary control. A surgery is not without potential consequences. First of all, as a major operation, you can run into issues in the hospital. It's a major anesthetic for several hours, so you could have problems with your heart or your lungs. There are always issues that have to do with infection or bleeding anytime you have any type of surgery. Now, fortunately, these are not very common, but they could happen, so you have to be prepared for them. One of these is urinary incontinence, or the involuntary loss of urine. Sometimes this is just a little drip of urine if you walk around or jump up and down or cough or sneeze. But rarely it can be a more severe type of a leakage where you don't have much control and actually have to wear pads or diapers. Many men have this temporarily for weeks or months after the surgery, but the vast majority will regain normal urinary function. For those of you who do not regain normal function and actually have problems with urination, there are solutions to this. The other issue has to do with your sexual function. If you have normal erections prior to the surgery, it's highly unlikely that you're going to have normal erections immediately after the surgery. But with time, if the nerves that are responsible for triggering erections, and which run very close to the prostate, if these can be preserved in what we call a nerve-sparing operation, then you have a pretty good chance of eventually recovering your sexual function. Now, it'll never be the same. When you ejaculate, there won't be any fluid come out. You can still orgasm. You can still have normal sensation. Your penis might look a little different. Some men notice that it's shortened a little bit, or there's a little bit of a curvature. These are physical changes that occur when we remove the prostate. None of them, however, will get in the way, if you will, of having normal sexual function. But be prepared, it won't be the same. It will be different. Many physicians use what we call a penile or sexual rehabilitation program, where very early on after the surgery, you're started on drugs that stimulate the blood flow to the penis. You've heard of Viagra or Cialis or Levitra, these types of drugs, We give them to you on a regular basis in small doses. And then once you start to feel the urges again that you want to have some sexual functioning, once everything else is healed up, then there are means that use artificial devices such as vacuum erection devices or needle injections with special drugs called intracorporeal injections to stimulate erections, which allow you to be sexually active. But at the same time, by stimulating these erections, it facilitates or hastens the healing process so that with time, you'll start to get your own spontaneous erections back. Now, not everybody does recover that kind of function, so this is an important issue to discuss with your physician or a sexual rehabilitation clinician. There are several different surgical approaches to the radical prostatectomy operation. The standard is an incision that is made just below the belly button down to the pubic bone, and through that space the prostate is removed and all the surgery is done. Another option is what we call minimally invasive surgery, or MIS, or laparoscopic prostatectomy. This is carried out through a series of small little incisions in the upper abdomen, and a scope is placed as well as working instruments, and this prostate is removed through the incision that is just above the belly button. The third approach is the use of a robot to assist the laparoscopic approach, what we call a robotic assisted laparoscopic prostatectomy. Some people call it the Da Vinci operation because the robot is termed the Da Vinci robot. This is a wonderful technology that has been available now for close to 10 years in some parts of the world. And the surgeon sits at a console remote from the patient while the robot arms manipulate the different instruments that are inside the body for surgically removing the prostate. There are some advantages to the robotic assisted operation, primarily excellent view of the anatomy, no tremor on the instruments, usually very little blood loss, and in general, a faster recovery from the surgery. But at the end of the day, inside, it's still the same operation. And the longer-term consequences that relate to urinary control or sexual function are still important. Now, what about radiation? It is also considered a gold standard. Perhaps it's the apple in the fruit bowl. There are some advantages to the radiation, primarily in that it doesn't require a major anesthetic and extended recovery time from surgery. There are a couple of ways of delivering radiation. One of them uses radioactive seeds, what we call interstitial implants or brachytherapy. These are little seeds that are implanted in all parts of the prostate, and they stay in the prostate and emit radiation over the period of 6 months to a year. And during that time, any cancer cell that tries to reproduce or divide will die because its DNA is damaged by the radiation that's in the nearby area. So eventually the cancer will die off, and this has proven to be a very effective means particularly for low-risk prostate cancers. One of the disadvantages of this procedure is that your prostate is not removed. So we don't know for sure if we got it all, if you will. We don't know if perhaps there was some higher Gleason score in your prostate. But statistics have so far borne out very good results for brachytherapy or interstitial therapy. Now, after the seeds are implanted, you'll likely require a catheter in the penis as well for a day or two. And a small percentage of men have ongoing problems with urination. These problems may be difficulty in urinating that could last for days, weeks, or months. And in the longer term, may be more irritative, meaning you have an urge to go more frequently, and maybe a little bit of trouble holding on to it once you have the urge. And rarely you can get bleeding in the urine, and even more rarely bleeding in the bowel movements. So neither treatment, surgery or radiation, isn't without early and late consequences. But in the realm of therapies, and when balanced against the progression dangers of prostate cancer, these are both exceptionally good treatments. So look into both of them. Decide which is best for you as an individual and for your partner and family, and have this discussion with your physician. So I hope you have a better understanding of what the prostate gland is, how prostate cancer develops, and what your different treatment options might be. Remember, everyone is different and every prostate cancer is different. So we have to tailor what is best for you for your own treatment. Speak to your physician, learn as much as you can about your prostate cancer and what the consequences of the different treatment options might be for you and your loved ones.